Ladies and gentlemen, Mr. Chairman, honoured guests, thanks very much indeed for asking me to speak today about two subjects which are close to my heart and which I'm interested in. Anatomy being the basis of surgery, it's the one, in my view, preclinical subject which surgeons need. Rather depressingly, it hardly seems to be taught at all in medical schools these days. I was sufficiently interested in it to do a BSc in anatomy as part of my dental training, and I like it, and it's stood me in good stead when it comes to surgery, of course. More latterly in my career, I seem to have ended up treating facial deformity and the natural extension of that, I believe, which is facial aesthetic surgery. Beauty is interesting, isn't it? We've just had this very interesting discussion. And it's preoccupied human thought over the ages, and lots of people have expounded on beauty and come out with memorable quotations from Goethe to H.G. Wells, who was the person who said beauty is in the eye of the beholder. I didn't realise that. To Groucho Marx, who said, as you can see at the bottom, she got her looks from her father who's a plastic surgeon. But what actually is beauty? Well, if we go to the dictionaries and look at what Webster's dictionary says about this, they say it's an aggregate of qualities in a person or thing that gives pleasure. And it's quite interesting, isn't it, that beauty is something that gives pleasure to the beholder, and this is why people value it, of course. And this is why people who can surround themselves with beautiful objects, and perhaps why billionaires don't marry ugly women. It's prized by society for lots of reasons, and there's lots of work being done on this and papers published on this which have shown that students who are good-looking get better grades. Good-looking people get better and more personalised service from their doctors. Criminals in court get lighter sentences if they're good-looking. And over a lifetime, people who are good-looking tend to do better in life, as Richard alluded to. They earn more money, they do better, they get better jobs, they're more successful at interviews. So there is certainly discrimination based on appearance in our society. This isn't very clear, but of course the public and people in general have latched onto this, and they realise that looking good is important. And there's a multi-billion-pound business based on cosmetics, and there's an increasing business based on cosmetic surgery. And if we look at the things that we're interested in as maxillofacial surgeons, the head and neck procedures, facelift here, between 2010 and 2011 is up 5%. Eyelid surgery up about 5%. Rhinoplasty up 5%. And this is at a time of financial stringency when people are being very careful with their money. So there's an impetus within society to look good for all the reasons which have been discussed already. Well, beauty is in the eye of the beholder, there's no doubt about that. And if you look at different cultures at different times, they have a different take on what is beautiful. Now, the ancient Greeks, and Koine Greek was the lingua franca of the ancient Greek world. It was just a particular type of Greek spoken. And they had this concept that beauty was related to being of the hour and being appropriate to time. So an older woman trying to look young would not be considered appropriate and therefore was not considered beautiful, which is in contrast to our ideas in our present society today, perhaps. This is the Daily Mail's take on beauty, and they took features from famous people, all of which are good looking, of course, and they amalgamated them to produce the ideal beauty and produce something which looks a little like an android, doesn't it, really, and a little unnatural, as you'd expect. But quite interesting. I mean, Angelina Jolie is being discussed, and of course she is incredibly beautiful. And she's got fabulous features. You know, she's got these, wonderful skin. She's got these nicely arched eyebrows, which are considered attractive, lovely eyes. And these rather interesting lips, which are something new, really, in terms of beauty in our society today. She's got this full, pouty look to her, which even 20 or 30 years ago wouldn't have been considered necessarily particularly beautiful. Ancient Greeks looked at Nefertiti as the acme of beauty, and again, fabulous features, but rather unusual eyelids, which would be considered slightly exotic today. Classical profile, and again, rather interestingly, there's a straight line here between the forehead and the nose, so the frontonasal angle here is almost 180 degrees. And if we look at the facial skeleton, it's relatively retrusive. It's tucked away under the neurocranium, in contrast to perhaps some idealized profiles today. This is a pre-Raphaelite beauty, which is pretty similar, actually. And so nothing really changed for 2,000 years. Coming to cosmetic surgery, and that's what we do, we approach it from 2 points of view, really. We are looking to correct an aesthetic anatomy, and we are the result of our anatomy. And we also look to reverse normal age changes, and we all undergo age changes. And I'd like to just say a little bit about both of these. Now, Thomas Overbury said that beauty was only skin deep. Well, as maxillofacial surgeons, of course, we disagree with that because we spend a lot of our time dealing with the bones of the face, the facial skeleton. And obviously, if you're going to move the bones of the face, if you're going to change the foundations, you're going to change appearance. And this comes into what we do in terms of orthognathic surgery. And these are the bones we deal with routinely. We can change the jaws, we can change the chin, we can change the cheekbones, and of course we can change the nose by means of rhinoplasty. Everybody in this room, more or less, will be familiar with the facial skeleton and the bones of the facial skeleton. But the salient anatomical points here relate to the upper jaw. Here are the infraorbital nerves coming out of foramina in the bones. Here's the mandible with the mental foramens, or foramina. When we're doing a genioplasty, we make a cut across here so we can move the chin, the bony chin point forward, and we've got to be careful we don't damage this. When we do surgery to the lower jaw by means of a sagittal split osteotomy, we're looking to avoid damaging the inferior dental nerve, which runs through the jaw and supplies sensation to the lower lip, etc. The prominence of the cheekbone is formed by the zygomatic bone, and the infraorbital rims are formed by the maxillary processes of the zygomatic bone here, and the zygomatic processes of the maxilla here. We have two very powerful tools when it comes to changing bony anatomy, and these are osteotomies, the sagittal split osteotomy and the Lefort 1 maxillary osteotomy. And this just represents where we make the buccal cut in the mandible when we're carrying out a mandibular sagittal split osteotomy. And this was described by somebody called Delpont. Previous to this, the original operation was described by Obvergeser in 1952. And he took the cut down to the angle of the mandible. And Delpont had the bright idea of bringing it straight down to the antigonial notch here. And the reason for that was it avoided disrupting the attachment of the masseter muscle here, so less swelling, less morbidity, and a greater surface area in terms of bone contact, and therefore greater stability when it came to maintaining the position that the jaw had been moved into. If we look at the medial aspect of the mandible, the medial cut is made above the mandibular foramen here, and this is the Hunsuck modification of Obvergeser's original operation, because he took it all the way to the posterior border and then hoped the split would go along the posterior and inferior border. This is a much better idea because it leaves the attachment of the medial pterygoid muscle undisturbed here, because the split propagates on the lingual surface here. So the pterygomasseteric sling is left undisturbed and attached to the proximal fragment of the mandible in a sagittal split osteotomy. And of course, this is a tremendously versatile procedure because we can move the mandible anywhere we want. We can move it forwards, backwards, sideways, up, down, close anterior, open bites, etc. So a fantastic procedure. This is Lefort 1 osteotomy. We're all familiar with this, where we make a cut in the lateral wall of the maxilla here. We detach the maxilla from the nasal septum and the voma, and we detach the maxilla from the pterygoid plates here to allow down fracture of the maxilla. And again, we can then move the maxilla anywhere we want, forwards, backwards, upwards, downwards, etc. If we're going to move people's faces about, it's as well to leave people looking better looking or more attractive than to leave them worse off. And so we assess them and we assess their faces and we judge their facial anatomy on clinical grounds. And these are the things we look at. We look for facial balance, we look for facial harmony. We look to see that the facial features balance one another. So we look at what we call facial thirds. And we look at facial fifths, and I'll show you this in a minute. We look at the balance between the nose and the chin, and we all know that if someone's got a big nose, it makes their chin look relatively small, and vice versa. We look at the relationship of the upper lip to the incisors to make sure that people show an appropriate amount of upper incisor. The books say 2 to 4 millimeters. We look at lip balance, and lip balance, by this I mean the amount that the lips project, and also the lip thickness. Now, we used to talk about 1/3, 2/3 upper lip to lower lip as being the ideal proportion. These days, we talk about 50-50, and this is the influence of Angelina Jolie, presumably, with her full lips. We look at the nasolabial angle, the angle between the lip and the nose. If someone's already got an obtuse nasolabial angle, and we're going to move the upper jaw, we may make it worse, and we may leave them with the dreaded Miss Piggy deformity, where you look straight at the nostrils. Not attractive. We want to look at the alar width, and in Caucasians, the alar width coincides with the medial canthus of the eye, usually. And we look at the paranasal fullness and the inferior orbital rims and cheekbones. Leonardo was there before us, of course, and here's his famous drawing of bodily proportions. And he was also there with faces, and he was there with facial thirds. So here's the upper third going there to there, the middle third going there to there, and the lower third going there to there. And he noticed that they were all approximately equal in well-proportioned, good-looking individuals. And we still do this. And if we look at this attractive individual, who has probably been cast for films by our panel member, this is Natalie Portman, and if you look at her facial proportions, of course, they're bang on. You know, her facial thirds all are completely equal, in contrast to this girl, who has got a facial appearance which has got a reduced height to the facial third and reduced projection of the chin. She's fairly chinless. If you look at a lip balance is good. The lips project equally. They're of equal thickness. Everything else is pretty good, and her teeth fit. So we don't want to change anything in terms of jaws, but we can change her appearance simply by carrying out a genioplasty to move the chin downwards and forwards. And what that gives her is better facial proportions and a more harmonious appearance. Similarly, this chap who came along wanting something done because he felt chinless, wanted to look more manly, and there he is with a simple genioplasty, just bringing the chin point, the bony chin point forward. This chap actually had an unusual profile with his tip of his nose to his chin almost a straight line. And he had a genioplasty and a rhinoplasty. It's to decrease the hump here, drop the nasal tip back, increase the nasolabial angle, or rather decrease it, sorry, to make it less obtuse because it's terribly obtuse there, and bring the chin forward. So just by doing these simple procedures, changing chins and noses, we can alter people's appearance quite radically. This lady had something slightly more radical done. She had a jaw brought forward and a chin and a nose done. And so quite a change in her facial proportions and appearance. Similar patient, again, chinless type. Then the jaw came forward and the chin came forward. So, you know, for relatively little surgery, a big cosmetic gain. This girl had vertical maxillary excess, incompetent lips, couldn't get her lips together, showed an awful lot of upper tooth, was retrognathic and retrogenic, and was treated by maxillary impaction, mandibular advancement, and genioplasty with this result. Similar sort of case, long face, very flat upper face, relatively prominent lower jaw, very flat labiomental angle here, and again treated by maxillary surgery and cheek implants to correct this mid-face hyperplasia. And similar thing for this girl. two, going from here to here. That's correcting deformity. If we move on to age changes, well, we all grow old, and fortunately it happens slowly, so we can adapt to it. John Keats said a thing of beauty was a job forever and its loveliness increases. Well, that may be, but it probably doesn't apply to people, because by and large people get less attractive with age. And this is a lady I met in Cuba recently.
And I bet she was great.
Well, well, if she'd spoken any English, I might have found out, you know. But I'm sure she had a lot of character about her. But she made her face was a fortune, because she made a living by selling photographs to tourists like me. This is Gloria Estefan. And I think most of us in the audience anyway would probably prefer to meet Gloria than the other lady. No? Okay. Well, maybe it's just me then. But anyway. So what happens with age? Well, there's all these anatomical changes which occur, and we lose volume, and by that I mean we lose subcutaneous fat. We get deepened nasolabial folds and marionette lines. We get orbital fat herniation, jowls, banding in the neck, all these things. Ritides are wrinkles. And this happens for these reasons, really. One is the effect of gravity, and it's true, everything heads south with age. We get structural changes in the skin, we get breakdown of collagen. Fibroblasts become attenuated, they give up the ghost and don't produce new collagen. We lose skin elasticity, we lose elastin in the skin. We get decreased muscle tone, we get fat pad shrinkage. And of course, the real killers when it comes to skin are smoking and drinking, and sunlight. And because these produce premature aging in the skin. And we get skeletal changes as well. And we get, for instance, bone resorption around the piriform aperture, which causes the nasal tip to droop, which gives rise to the feeling that people's noses get bigger with time. They don't get bigger, they just change shape. I'd like to talk about two of the common procedures we do to reverse these age changes. One is facelift, and the other is blepharoplasty. And facelift is a fantastic procedure, and the aim is rejuvenation of the lower face and neck. We get rid of jowls, we correct skin laxity, we get rid of marionette lines, and the bottom part of nasolabial grooves. A facelift can be combined with other procedures, eyelid procedures, brow lifts, etc., etc. But it must be remembered that a facelift in itself is a major surgical procedure. It's going to take about 2.5 to 3 hours to do. There is morbidity attached to it, there are complications attached to it. And of course, the worst complication is getting the unaesthetic result. Because if anybody, we're saying about Los Angeles, where you see people being pulled tight. Well, I was in Aspen recently, and you see the ladies who never ski, of course, but they've got the gear, and you can spot the facelifts at 100 paces, because they've all been pulled too tight. They've all got ears which have been pulled. We call it the pixie ear deformity. They've all got absent hair in the temporal hairline, and they've been overdone. They've been pulled too tight, and it's unnatural, and it's basically just poor surgery. There is anatomy at risk here, and of course the main thing at risk is the facial nerve. And the further you undermine medially, the more superficial the facial nerve, and the more at risk it becomes. There are other nerves, sensory nerves. I want to say a bit about the SMAS layer, because this really is the key to most modern facelift techniques and getting good results. Facelifts have changed, and the first facelifts were described by, well, over 100 years ago by Hollander, and all he did was excise some skin in front of the ears and stitched it up, and it just tightened the skin a bit. 10 years later, somebody undermined the preauricular skin, pulled it tight, excised the excess, and stitched it up. Today, there are lots of different types of facelifts described, and everybody has their favorite, and everybody does it slightly differently. These are the ones I do. I do a SMAS facelift, I do the short scar facelift for the less severe cases, and I do the mini lift, which essentially is a subcutaneous lift, really, for people who really shouldn't be having them, and I mean smokers, because not many people will do facelifts on smokers. You've got to be very conservative. We talk about the SMAS platysma system. This was first described by Skoog, who also described some other things, didn't he? Cleft lip and palate type things. And the anatomy was further described by Mitz and Peroni in 76. SMAS stands for the superficial musculo-aponeurotic system. And it's literally it is essentially the superficial fascia of the head and neck, and is synonymous with temporoparietal fascia, and is continuous with the galea superiorly and the platysma inferiorly. And it's that connection to the platysma that we use to tighten the neck and to produce nice results in the neck. So just to show you where it is, skin, subcutaneous tissues, and here's the SMAS layer, and deeper layers of fascia. In coronal section, here it is, and it's continuous up here with the galea, which of course joins onto the frontalis muscle, and then going inferiorly, it joins to the platysma muscle in the neck. This is just really to make the point that when we do a facelift, essentially we're raising our flap in this plane, and what this does, of course, is disrupt the normal perforating blood supply coming from deep. And the skin survives on the subdermal plexus. And this is why in smokers who have prejudiced and small vessel disease, basically, they are at risk in a facelift. They're at risk of getting sloughing of the death of the flap, basically. And to produce a fabulous result then for the skin to drop off is not good. I just want to talk about this lady who is a lady who came to see me, and a lot of people come and they just say, what can you do? What do you think? What can you do? And I knew how old she was, and she was 50. And she's not good for 50, basically. And she knew, you know, she didn't feel good about herself. And she's got all these signs of, in my view, premature aging, because I think 50 is young. She's got nasolabial grooves, she's got the marionette line, she's got jowls, and she's got banding in the neck, and her skin's not in fantastic condition. And I said, well, what you really need probably is a facelift. You know, her eyelids, well, she's booked into her eyelids done, actually. I mean, but, you know, they can be improved. But the major issue, in my view, here was the neck and the lower face. And so she's a pretty good candidate for a facelift. Now, I'm just going to show you a little clip here, just to show, now don't look at this, the people who are not medical. Look at something else. But this basically is just to show you how one way of dealing with the SMAS layer. And
directly
there is a commentary.
Here, you pick up the back edge of platysma really and the SMAS layer and elevate it so it comes straight up. And so the first stitch I'm going to put into here, into the mastoid like that. And the second stitch is going to go into their big bites.
So what I'm doing is picking up the SMAS and basically elevating it to tighten the neck.
See what's happening? Okay, so I'm going to tie that now. And this is a 2-0 Maxon I use here. Okay, just lay that down. Lay that up down there. 4 throws on Maxon. Thank you. Cut, please. Okay, thanks. And then I'm just going to work my way across the face like this, just plicating the SMAS. There's different ways of dealing with SMAS, but I think it's safe to plicate. I've done SMAS flaps, I've done SMAS excisions, I've done double breasting it, I've done all kinds of stuff, but I've gone back to plicating just because it's safe, it's easy, and it gives a nice result. And stitch please, cut, sorry, and so that's that. And I'm burying these knots so you can't feel them because Maxon's a bit spiky, you can feel it under the skin. This is a 3-0. And so we're just working our way. I'm going to do the same again here, just working the way across the face like this. I want to take about 3 or 4 or 5 stitches to do this properly. And that's tightening again, just elevating the corner of the mouth there. That's quite nice. Just sit that down there like that, and like that, and like that, and like that. Scissors and cuts. Thank you. And just perhaps one more I think we'll do for this lady. Just got to cover it up, pucker the flap. If we get too close to the skin, it puckers the skin. So just make sure that that's okay.
I think you got the idea. As I say, what we do is we tighten it, and treating the SMAS by plication has various advantages in my view. One is that it's relatively safe. It's easy, and raising SMAS flaps is not easy. The SMAS layer can be pretty insubstantial, and you can end up with nothing to tighten, actually. And of course, we're well clear of the facial nerve, which is important. We're also restoring volume to the face as well. So, volume is something we lose with age. So, it has those advantages. Now, there are lots of people who do lots of other things with SMAS layer. That's just what I do. Having done that, we re-drape the skin, and you can see there's a lot of surplus skin here. And we excise the surplus and stitch it up. Anyway, so there's our lady beforehand, and there she is afterwards. And what we've tried to do is clean up the neck, define the jaw, get rid of these marionette and some of the nasolabial lines, and it's a substantial improvement in my view. Just someone else here who came along with all this stuff in the neck here and wanted the neck cleaning. Again, it gives a nice clean neck here and defines this mandibular cervical angle quite nicely, which had disappeared there. It gets rid of these marionette lines. This lady had a short scar lift, it's a lady about 55, and just getting a bit of early jowliness here. And the face takes on a square appearance with age due to fat pad descent. And this is restoring the triangle of youth. And from the side, you can see the difference in the neck. She's getting this sort of, baggy, turkey-type neck. And here it is with the neck cleaned up and defined. And it's a youthful look. If we move on to eyelids, the anatomy of eyelids is complicated, or slightly complicated anyway. I mean, we know about it because we routinely approach the inferior orbital rim to deal with fractures of the orbit. But the key points really are the fat, muscle, and layers, and then the orbital septum, which is here in the lower lid and here in the upper lid. And this restrains the orbital fat pads here. And this is important because as time goes on and we age, we get various things happening. We get skin laxity, we get descent of the brow, we get descent of the lateral canthus, we get skin redundancy in the lower lid, and we get herniation of fat. And this causes the fat bags that we see. And just to show the progression from the appearance of youth with a short lower lid, early bags. And what's happening here, as I'll show you in a moment, is various fat pads are moving south, lengthening the lid and deepening this groove here. And of course, in extreme old age, the lower lid is really, quite long. Oops, sorry. And what happens when we start to get bags forming is that the orbital septum weakens and you get herniation of fat. We also get herniation of the suborbicularis oculi fat, the SUF layer. We get weakening of the SMAS. So here's the SMAS layer again. And as that weakens, the malar fat pad descends. And so here we have the malar fat pad. Here's the SMAS, which is stretching and weakening, and everything's heading south. So as this goes down, we get the nasolabial grooves developing here. This is, which should be up here right under the eyelids, is disappearing, leading to the lengthening of the lower eyelids that we see typically with age. There are 2 fat pads in the upper lid, middle and medial, and 3 in the lower lid. And they're immediately beneath the orbital septum, so to get at them you have to incise the orbital septum. And classically, in blepharoplasty, bags are reduced by removing fat and tightening the septum. There are other techniques too which involve redraping this fat. And the argument is that because we're losing volume anyway, the last thing we want to do is be removing fat, which is going to decrease volume further. However, if done judiciously, this gives a good result. If you overdo it, of course, you can leave people looking hollow-eyed, which again is cadaveric, which is not an attractive look. The proportions we look for distance from the lid margin to the brow are approximately a third below the supratarsal crease and 2/3 above it. So just to show you some examples, this is a lady who came along, again, lady of about 50 probably, who had these, well, redundant skin in the upper lids, such that the skin rested on the eyelashes. And she said, you know, she came along, she said, I feel tired. And of course, elevating your brows all day long so you can see is tiring. And so she had an upper blepharoplasty, and what it did, it just defined her eyelids again. It made her look more alert. People started commenting on her eyes. It improved her self-esteem. Another lady with the same sort of thing, and just prematurely aged around the eyes, really. She needs a lower lids doing. Same thing in the upper lids, redundant skin. If we look at lower lids, here's somebody with early bags, just, again, treated by fat excision, redraping the skin to give this look. Nice, youthful look to the outer canthus to give this slant to the palpable fissure. Sorry, skipped on. And here's a lady who had both upper and lowers done. Surplus heavy upper lids and festoons in the lower lids. And this is due to multiple dehiscences in the orbital septum causing multiple points of herniation, leading to this multiple bags, really, serial bags. And there's a trap for the unwary. This is a lady who came along to have her eyelids done, and of course she doesn't need her eyelids doing, she needs a brow lift because she's got heavy brows. And she just had a simple lateral brow lift, which just raised these heavy brows away from her eyelashes. So, ladies and gentlemen, what conclusions can we draw? Well, I think we'd all agree that a basic or a detailed knowledge of anatomy is important for anyone undertaking surgery. I think that's a given, isn't it? Appropriate surgical training is important. There's no doubt about that. However, in cosmetic surgery, of course, until recently, there's been no formal training in cosmetic surgery. And what's happened is people from various specialties have taken their generic skills, been to a few courses, and then had a go at doing it. And things have changed now because we've got what we call the training interface group set up now for training in cosmetic surgery. This takes trainees from appropriate specialties, which is maxillofacial, ENT, plastic, eyes, and breast, and gives them fellowships, 4-month fellowships. There are 18 4-month fellowships a year in various units around the country. They're very popular and seem to be successful. And there's several people in this audience, none of whom I can see, who have either done them or are in the process of doing those fellowships. We also have what we call the Academy of British Cosmetic Practice, which is a group that was set up at the behest of the last government to look at really the regulation of the cosmetic industry, because there is no regulation. Anybody can do anything to anyone, regardless of their training. So, for instance, you know, if you're a beautician in a salon, you can buy a laser, no problem. Well, lasers are dangerous, and you can treat people with lasers, just like that. There is no regulation at all of lasers in this country. And the idea was that the Academy of Cosmetic Practice would oversee practitioners. So it would be a voluntary registration, and the idea it would be like a kite mark. So if you were registered with it, it gave some sort of respectability to you, because your training would be scrutinized. You would have to submit audited or evidence of audit every year, lists of what you were doing, etc. And it's long overdue. It's struggling to get off the ground because there's no money, of course. The government, having set it up, quickly lost interest in it because presumably it wasn't a vote winner, I don't know. And of course there is now interest from Europe, and this stands for the Committee Européenne for Normalisation. It's in French, excuse my French. And what that's looking at is, again, trying to harmonise aesthetic standards or standards of aesthetic practice throughout Europe. Well, I sit on this, and you know, I suspect, like most European things, it's fraught with difficulties to get anything done because half the European countries want one thing and the other want the other, and one country has pulled out completely, that's Belgium. And I suspect we're all going to be left doing our own thing. But I would urge anybody who's got an interest in this, in training, to consider a cosmetic fellowship. And that's all I've got to say. Thank you.